Good afternoon. Thank you so much for having me. I feel honored to speak in front of you. Please, if I'm repeating anything that you already know, I was told, don't know much about this. I'm here to educate you. So if it's new knowledge, yay. If it's something you've heard before, forgive me. I always just assume everyone knows nothing about the pelvic floor. And then I'm happy to answer questions as we go through it. I don't have a long presentation, but I do tend to get passionate about certain things and then can talk quite a bit about it. All right. So the pelvic floor function, I think, is familiar to most of you. Yes? Yes? A little bit. So for us, as physios, we look at it in terms of how the rest of the body functions with it or without it. And a lot of the time, people tend to focus on one aspect, which is either the hip, the knee, the fractured pelvis is now healed, patients happy, send them home, but they forget about all the other aspects to it. You might need physio after that. Not pelvic floor though. Right. So that's just a list of the function. This is what I was talking about earlier. What's quite important is it's the pelvic floor, the abdominal muscles, the diaphragm everyone forgets about, and then the back muscles. And together we create that stability, that intra-abdominal pressure that we are quite passionate about. Again, if you know this, just tell me to move along, because physios don't know this, so I tend to explain that to them. Right, so function and dysfunction. You know the normal, you know the abnormal. So where do I fit in? When the patient presents with chronic constipation, coughing, sneezing, they're overweight, they're inactive, they've had, which is not on this list, multiple pregnancies, a pregnancy depending on the person themselves. So maybe they've had a history of constipation, they've had their first pregnancy, they've delivered via C-section, NVD, doesn't matter. Oftentimes there is something that was there and is now exacerbated following the pregnancy. So recurrent urinary tract infections, we tend to ask some more questions. We look at other aspects, and what's nice is when you've done your evaluation and I do my evaluation, we can both get the patient to a more comfortable, happier lifestyle. Recurrent heavy lifting, so with our population at Tygerberg and what filters into us, we're looking at the factory workers, we're looking at carers, we're looking at the nursing staff. So that's their heavy lifting we're looking at, not necessarily the the bodybuilders with their weights, but we're looking at the day-to-day heavy lifting and how this contributes to it. We often have difficulty trying to explain to the employer why it is they've got to put them on light duty, because in this factory setting they work in, it's not always easy. Bristol stool chart, patients find it amusing. We do use this. So we as physios pull this out and we go, okay, so which one of those look familiar? They all look at us with big eyes and strange expressions, but we ask, is it like an uncooked sausage? Is it little droplets? What is it that's coming out of you? Because that's important for me to know. So yes, we as physios understand this chart and we ask about it. So the impact on the quality of life, you know it and I know it. But where do I fit into all of this? Where does the physio fit into your management of the patient's condition? And can I improve their quality of life without having access to a urogynecologist? We don't always have that at our disposal. So quality of life impacts such as physical limitations, psychological, social, domestic, occupational, sexual. What we're finding in our realm is that most women walk around with the shame and the fear. They don't know that they can ask for help. They just assume that this is something they've got to live with. And I think you might have come across some of these things as well. Yes, no, yes, yes. Old knowledge. So very excitingly, local research was done by me with the help of Dr. van Rensburg and Susan Hannekom. Thank you so much. We're working on getting it published. I went into 10 different public health facilities, primary health facilities. I went to 10 different day hospitals and clinics. I sat down and I asked them about their bodies, specifically urinary incontinence, if they had any incontinence, and then a little more about it. So Why did they seek help? So we know there's prevalence. We know we've got treatment available. There's you out there. There's me. But why aren't they asking for help? So what is the missing component? Why aren't they coming to us? We should be incredibly busy according to the statistics. So in the descriptive cross-sectional study that I had done, there was one facility I did not get access to, and that was both time dependent, so this was hitting December of that year, and it was just a master's, so we didn't have to try and survey all facilities. I did meet my numbers, as you'll see in the results. I managed to get 667 women to talk to me about themselves. My prevalence that was found amongst those 667 women was 28%. I should be busy. I'm not that busy. Only 25% of those women asked for help. So there are 75% of women with incontinence sitting out there not asking for help. We know that the average age would be around 50, and this is because women are going through menopause, they're done having their kids, their lifestyles are changing. So that was my median age, and that was not new knowledge. However, I had women aged 19 to 79 who completed my survey. Women who had sought treatment had a poorer perception of their general health. So this talks to the quality of life impact. So those were the women who said, I'm just a sickly person. You know, I'm constantly in the hospital. I'm going to multiple clinics at the hospital. It's not a good life right now. Barriers that were listed. So I had compiled a list of barriers ranging from it's as a result of childbirth, it's a result of aging, to cultural, religious. Some of the things that came out of the international research was cultural and religious reasons, such as it's taboo to talk about this. I can't go to a gynecologist without a male relative accompanying me. I can't talk to anybody. I'm living in a foreign country where they don't speak my native language, and for that reason, I don't know how to express myself and explain my condition. I don't know that I can seek help for this condition. So most of the women reported lack of knowledge. So when we talk about lack of knowledge, this is that there is available treatment, that surgery is not the only option. So it's just basic education that the condition they're sitting with is a medical condition. It's not just an overweight condition. It is something that can be managed medically and helped with and resolved, which is what they did not know. The ability to cope with the current presentation and symptoms. So a lot of them had coping mechanisms they had put into place. So this would be changing the way they dressed, so that if they wet themselves in a skirt, they could just continue walking. They would stop going to family functions. They would not pick up the grandchildren. They would remain at home by themselves. Their interaction with their family members was impacted as well. So not being able to sleep next to their husbands, something as simple as that, because they were fearful that they would wet the bed. They stopped intercourse. So those are all the different components that we asked about. And we still have to delve into the specifics as to what the numbers were, and that's what we're working on with the article. So 38 women, and that's only 65%, sought help and were offered treatment. So of the 25%, a further reduction, just over half of that, 25%, had been given help. And of this percentage, only half the women were satisfied with the management. And of the treatment offered, one person got physio. One person received physio. That, to me as a physio, is sad, but means I've got to ask the question, why? So physiotherapy assessment, that was the research that I conducted, but as a day-to-day physio, what do I do? Why do you want to send your patient to me? So I do a full subjective exam. My subjective exam includes a lot of the questions you would ask. So what's nice in our urogyne clinic is that They ask most of my questions. I look at the sheet and I go, are you still constipated? Yes. Are you still leaking? Yes. Are you still getting up 5 times at night? Yes or no. And that then allows me to go through this process a lot quicker. In my private practice, I have an hour to an hour and a half with a woman because I am delving into things that no one's asked her about. My objective exam includes a vaginal exam. So as a pelvic floor physio, I've done extra training. I am qualified to do a pelvic floor exam. My exam's a little different from yours. I don't use speculums. I don't do scrapes. I use my hands. I don't do ultrasounds. I use my hands. So I would do a pelvic floor exam, and I would orientate myself, bladder, bowel, cervix, if there is one. I would go and find the pelvic floor muscles. We would try and orientate the pain. So if it is a pain condition, we would map the pain starting from the outside in. So dermatomes, myotomes of in and around this region, as well as on the labia, inside, superficial versus deeper pelvic floor. Is there any scarring? If there's something I'm uncertain about, I'm going to refer back to the gynecologist or the urogynecologist who has referred to me. If it's not been a referral to me, I usually tap into my resources. So who are my gynes and urogynes that I know look at things the way I do? Unfortunately, not all of them do, and I think you know this. So breathing and pelvic exam, I mentioned the pelvic exam. Breathing, we all breathe. And I mentioned earlier the diaphragm and the abdominal muscles. And what's interesting now is there's a trend towards Pilates. Do Pilates and your pelvic floor will fix itself. No, it doesn't. Because what do they do in Pilates? They work on bracing. It's this bracing motion. It's deepen the ribs, connect the ribs to the pelvis, hold that position. Now move your legs, move your arms. Do all these wonderful positions, but hold everything together. What they're forgetting is that my pelvic floor doesn't function by itself. My pelvic floor muscles function along with my abdominal muscles and my diaphragm. So if I'm breathing apically, nothing's going on down here. And if nothing's going on down there, is this functional? Not necessarily. So a lot of the times, we meet these women, wonderfully been doing Pilates for the last 3 years to try and get the pelvic floor going. And now they've got to unlearn the breathing pattern they've learned. So sometimes it's as simple as changing the breathing pattern and then, woo, I got my pelvic floor. I can feel what's going on. It feels so different. I can move again. And I'm not knocking Pilates. Pilates is amazing in certain conditions, in certain circumstances. But with the pelvic floor, we need that pelvic floor exam. What can I treat? So what can I treat? I had a GP call me on my way here asking, so she's heard from a colleague that she should perhaps chat to me about whether or not I'm the appropriate person to treat this patient. Patient has a long-standing history of dyspareunia. When she examined the patient, she had difficulty with the speculum. This is a 52-year-old, married, has had kids, long history of dyspareunia. And she found a cyst and thought the cyst was the source of the pain. Sent her to the gynae. Gynae said, no, man, those are completely normal. Don't worry about that. Now what? It's not the cyst causing the pain. What do you tell this patient? I'm sorry. So the patient asked the GP for Botox into her pelvic floor. I don't know about you, but I know the last time they spoke about laser, I clamped down thinking, no, thank you. No, thank you. No lasering going on down there. But she was so desperate, she wanted Botox. I don't know where she got her information from, but thankfully, her GP knew one of my referring GPs who could then say to her, no, 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 you need to think about the physio. So you've ruled out any contributing conditions, the cyst perhaps. And I said to her, if I find it's not the pelvic floor, I'm going to send her back to you, and I'm going to give you a list of doctors that I think might want to look at this and give you a different opinion. Not knocking the gynae, I just don't know why the gynae did what they did. So, chronic constipation. What do you tell your the patients you see with chronic constipation? Yes, some Movicol, some Synacot. drink more water, exercise. So I'm a 56-year-old factory worker. I leave at 5 in the morning. I get home at 6. Don't see my kids. Very annoyed that I'm here. I've spent the entire day waiting for you. And you telling me, drink water, exercise, have some tablets. This lady's going to go back and go, it's like the diabetic clinic. They're telling me to eat a diabetic diet. But I can't afford your nuts and dried fruit and whatnot. How else can we make this easier? So what we do, I'm going to use your box. Simple thing. Change the position on the toilet. So this is a bit short, but the toddler stools, best height ever. Not the plastic step. The toddler stools is the most appropriate height for toilet positioning. I'm short. This is not going to work for me. I need something a little higher than this, but that's okay. I'll manage. So in this position, I can, lean forward. I can lean forward. And in this position, I am pulling my tailbone out the way. I'm also relaxing my pelvic floor muscles, which means my anorectal angle is so much better. So I could sit there. Physio said I need to breathe into my belly button. I need to relax. I've got to get to work. So in this position, I'm in a more ideal position to evacuate my bowels. And then with those chronic constipation, ladies and gentlemen, I say spend an extra 2 minutes. So take the timer on your cell phone. And if you've got a list of things you've got to do today, sit and make your list while those 2 minutes are ticking off. So you are active, but relaxing so that you can evacuate appropriately. And we had a lady not so long ago in our clinic who couldn't understand why she was constipated. She's got the right diet, she walks every day, she drinks enough water. Everything else is functional. Why is she constipated? We taught her this. Her life was changed. She didn't need to go back to them. She was better. All we had to do was change her position on the toilet, and she was going every day like a dream, living so much better. So something as simple as that. You can teach them this, and failing this, then you just send them to me. I'll fill in the gaps. Right, so a little more about the squatting. So it's a bit difficult to get people to do that on the toilet, right? We see kids doing that. Toddlers go and they just go, I'm down there. But try getting an adult to do that, not so easy. What do most people do when they sit on the toilet? This. Mental note, have a look at what you're doing on the toilet. They do this, and they push, and they hope to God that it comes out. And they sit there, and they sit there, and nothing happens. Something under the feet. For your lower income households, telephone books, a brick, a toilet roll, more than enough. If you're out at a conference, take the little basket that's in the bathroom, the little bin, turn it on its side, put it under your feet. And I guarantee you, your conference is going to go a lot easier. Okay. Prolapse. So we all know the guidelines, right? When should you send the patient to me? So we've had those ladies where they've got the procedentia and it's not pretty and it's not nice. But you know what? I can still make her quality of life a lot easier. I can still treat her urgency. We can still change their toileting positions. We can help them with the breathing and the relaxation. We can teach them other things to keep an eye on. If it is a surgical candidate, would be nice for me to see them beforehand as well. We do that in our clinic so that I can do my checklist. Is there anything that's going to lead to the failure of your surgery? Because you're still constipated, you're still bearing down, you're still breathing the wrong way because you can breathe the wrong way, as we've heard, diaphragm, abdomen. So all those things, and a lot of the times I look young. A lot of the times I look young, and I'm female. So when I sit and I ask, is julle nog in team? And they say yes. I say, so how's it going in there? Not so good. And I ask, why not? And then they'll tell you everything. But culturally, demographically speaking, if I were male and older, how likely is it that she's going to divulge that to me? So my demographic makes it a little easier in Tygerberg for women to tell me things. And then there are times where I go, okay, this is not a physio thing. We've got to send you to social worker, and we've got to send you to psychiatry and psychology, and definitely not me. But we've allowed that platform to ask those questions, say they say, and send them to where they need to go. Back to the prolapse. I told you, I digress. The prolapse. So I can improve your stats with your surgeries by making sure they've got good pelvic floor muscles, they are functional, making sure they don't get back to where they were with the initial prolapse. So how are they lifting those heavy boxes in the factory they work in? What are they doing with the kids and the grandkids? Because how many of these 60-something-year-old women are looking after their grandchildren and still picking them up after they weigh 20 odd kgs, they're still picking them up. So we'd actually teach them to push it back in, activate the pelvic floor, sexual positions that might be more favorable depending on the type of prolapse they have. So we'd have the time to discuss all of this. But I get the feeling we'll be more busy now. Incontinence, urinary incontinence, fecal incontinence. We do rectal exams only when really necessary. It's not nice, no one likes them. So we usually are able to help the women identify their pelvic floor muscles through a vaginal exam. And in doing the vaginal exam, they then get a better contraction of the rectum. And in getting that anus closed, you then have a woman who's able to control herself better, get to the bathroom on time. One of the other things that I've seen as well quite common is that they don't give themselves enough time to evacuate their bowels completely. So those are the women who tend to have smears on their underwear between bathroom visits. So they've had a bowel movement in the morning and they're quite regular. Every morning they have their movements. However, they find as the day progresses, something slips out or they've got smeared underwear. Those are the ladies that don't give themselves enough time in the bathroom. They're not breathing appropriately. It's not dietary, it's not water. It's other things that I will explore to try and identify. And sometimes I've got to sit and go through their day-to-day routine and say, okay, this is an opportunity to try that. And at that stage, you can do this. And let's give it a week, see how it goes, come back to me and take it from there. Urinary incontinence, die knijpers. Let's get the pelvic floor going, wake it up. We do explain to women as well, both at Tygerberg in the private sector as well, that the innovation goes to the bladder, it goes to the pelvic floor, and then they can conceptualize this. And in understanding their bodies better, they buy into the program, which is rehab, and they actually follow through with it. Ooh, flatus incontinence. Should we be worried about that? No? Yes? Maybe? You're 65, you've had 6 pregnancies, passing wind when you don't mean to should be a good joke to the rest of the family. No, it's not nice. Send it to me. I'll get it going. So, dyspareunia, my favorite topic. It's most taboo. No one wants to talk about it. And I know even at the conferences, there's always such a small turnout when we're talking about sexual function and pain. Dyspareunia is not just the muscles. It's not just trigger points in the muscles. Oftentimes, it's that anticipatory pain. So I'm anticipating the pain that I'm going to get with penetration, so I clamp down. I might be thinking, breathe, relax. I've known this man for 30-odd years. We've had kids. Why is it suddenly painful? I've had this surgery. Doctor's done a brilliant job. He understands. But why do I keep getting these trigger points? Why is that painful? So trying to establish at which point during intimacy they're experiencing pain will help me establish what the underlying condition or problem is. So is it psychological? If it's psychological and it's something we can identify and they can work on themselves, good to go. But sometimes we've got to refer to the sexologist. And we are fortunate in the Western Cape to have a few we can choose from that's in proximity to us. Sometimes it's psychological. So they really don't like the person they're married to. He's cheated on them. She's sort of forgiven him, but she's the stay-at-home wife, so she can't really leave him because financially she's dependent on him. And she's got to give it to him. She doesn't want to. And in that instance, you say, your body's saying no, thank you. Your body's saying no entry, and what are you doing? You're just allowing him to do what he wants. So sometimes it's a little bit of patient advocacy, where you're going, it's your body's telling you things, you've got to listen. Don't. But if you find yourself in a situation where you can't leave him, religious, cultural reasons, financial reasons, and you really want to be able to just have less pain, I can help you with that as well. So breathing, because my abdominal muscles, my diaphragm, and my pelvic floor work together. When I'm holding my breath in anticipation of what's about to happen, my pelvic floor is going to respond as well. So dyspareunia is not just trigger points in the pelvic floor. We also do chronic pain, education. Where time allows, we try to make time for it as well now, because there is that time lag between the different clinics. So if we're referring them to the chronic pain clinic, how long is it going to take them to get there? So if I can give them a little bit of insight and not make them feel like it's all in their head, then it means they understand their bodies better and they buy into the treatment I'm offering them, which could be the breathing exercises, the mindfulness, the normal exercises, going for a walk, just debriefing themselves, going, okay, this is why I'm sore, and this is how I can help my pain. How do you teach the pelvic floor contraction? So you might be sitting out in a little dorpie out in the platteland, and you now have this person in front of you, and you heard about pelvic floor contractions, and you know if you do that, it's going to stop the leakage. So what do you tell them? But in your assessment, I know you do evaluate the contraction. How do you describe it? Do you go, imagine you're trying to stop the wee. Can you squeeze and stop the wee? Yes. Yeah. I know. Physios that don't do this work also do that. So please, I would like you to try this. So you can have it just say, kan jy jou knypers knyp? Can you squeeze your pelvic floor muscles, the little muscles between the legs? Can you do that? Okay, she has no concept of what I'm trying to ask her to do. So perhaps contract your anus, so close your anus. I like using flowers as examples. So you know those little flowers that are coming out now, they close at night and they blossom in the morning. And I say to them, imagine it's a flower and you're closing your flower, and then you gently draw it forward and lift inwards. You will be impressed with how different that contraction is. If you don't want to explain the flowers, you can send them to me. And then abdominal breathing. So when we teach abdominal breathing, we're very hands-on. You'll see I touch. So when you teach abdominal breathing, hands on the belly button, you're welcome to join me. I would like some participation. So find your belly button, hands on your belly button, close your eyes, and imagine there's a balloon behind your belly button. And as you breathe in, your balloon expands. And as you breathe out, it flattens out again. Doesn't that feel calm? Yeah. Sometimes you just want to calm them down. I mean, most of the women go, oh, you're going to do a pelvic floor exam? You're going to go scratch it down there. The doctor was just in there, and it's not so nice. And I go, I promise it's not like that. It's just, and what I do is, because you've seen it as well, women are clamping down those legs are shaking, they're holding their breath, you're struggling with the speculum. Tell them, give them something else to think about. Let them do the abdominal breathing. It's going to be easier for you and easier for them. Any questions? No? Thank you. Yes?
Thank you, Lonese.
There is a question.
Any questions? Mrs. Jacobs?
Yes.
We have kind of, I don't know the name of the exercise where you actually more looking at it before like a delivery, where we have maybe openly gravidas who never delivered before. They have a lot of diabetic patients and high BMIs and previous seizures that are going to be back.
It would be best to try and teach them that before they get to that big moment, if it's possible. Yeah. It would be, if it's possible, would be nice to teach them before this very stressful moment in their lives, because they're distracted by what they're feeling. If it's not possible, which often is the case, you're getting the woman and she's never had antenatal possibly, or she hasn't had this being taught to her. So what we usually try and do is bring awareness to this part of the body. If you can put your hand there and say, can you feel my hands here? Yes, I can. Okay. Now take a deep breath into your belly. There is not much space in someone who's about to deliver, but say to them, bring that awareness back and say, take a deep breath into your belly button, and as you breathe out, imagine the blossoming flower, because what are they going to do? They're going to close their eyes and they're going to picture this flower opening up. And as you're sitting now, imagine your anus is this flower, and as you breathe out, it releases. And I can guarantee you, they'll get the feeling you're trying to get. When pushing, I don't like stepping on the territory of the midwives, because they are better experienced in that particular field. We try not to get involved. We've been asked to teach perineal massage in preparation for it. I send them back to the midwives. I don't do perineal massage. I will help you afterwards. Okay. But trying to breathe and relax into it and to visualize the opening up can be a nice tool as well. And the choice of words has a big component. Any other questions? Yes?
Yes.
Thank you very much for the lovely talk. We see so many patients with these problems. And to be honest with you, I have sort of, even in myself, I've sort of given up hope. Consent. I don't know, but
Thanks for your honesty. No, thank you for your honesty.
Honest,
Yes.
because I just presume that there won't be a physio available, or like for instance, I do a clinic at Eastern Hospital. I spent a lot of trouble to get to contact with the physios there, and they were quite sort of unaware of the concept even of a pelvic floor physio. And then obviously the logistics of the patients, I find
Having
often
to get
for
to
them
Tygerberg.
come back to come and see the physio. And then maybe also, we are so sort of, especially in the government sector, we are so sort of focused on surgery and medicine that we sort of feel like, is there really evidence that this really helps? Isn't it just sort of a bit of attention for the patient?
Okay.
Those
Yes.
are the
Yes.
things that I think about.
Yes.
And obviously, this lecture has now once again brought under my attention that it's something that I'm completely missing out on using for the patients. So maybe just some practical advice how to get the patients to you. Are you there 1 day a week, or are you there 3 days a week?
Okay.
How long is the waiting time?
So in our aspect of the clinic, we are sessional physios. We are 2 at Tygerberg. We are only available on a Tuesday afternoon. We do group sessions and individual sessions. The general incontinence, overweight, prolapse type conditions, they tend to resolve quite nicely within our group sessions. We do 4 group sessions where we cover a multitude of topics that is relevant to the condition. And then when we pick up that some of them are experiencing some difficulties, we get individual sessions where we would do a pelvic exam and help them identify the pelvic floor and any other specific things that they might not be doing or contributing to what they have right now. If it's a pain condition, we see them immediately for individual sessions. I completely hear your complaint. I've seen patients come from the day hospitals and the clinics and the outliers, and they've been referred to the physio taught them something, but they've had their pelvic floor physio and it didn't work for them. So they come to us very discouraged as well, because they've done the physio. Why can't I just get the surgery now? I've done it. The problem we have right now is we've got very few physios who are in the field of pelvic floor rehab, firstly. Secondly, even less in the public sector. So I'm in discussion with my professional society to put together a little crash course, if you will, in how to manage these patients until they can come and see us. So we then get the more difficult cases, the pain conditions, because that takes more experience and more time, and they can manage what they can. So teaching the correct seating position on the toilet, teaching the breathing, teaching a bit of stretching, body awareness, that they can do. So I am trying to address that. But yeah, so hold thumbs. We can get to them, and that they'd actually show interest. So I can't really walk into a clinic and go, you've got to do this. I can say I'm providing the following coursework. You are welcome to do it, etc., etc. But thank you so much. I hear you. I'm just as saddened sometimes.
Can I just ask you a last question, because of time, just for the registrar's sake, what is Levater-Ani trigger points? You know, you refer to trigger points, but I think, you know, you said, you know, you explained how you would do an internal examination.
Yes.
You don't use a speculum and you only use your hands, but just for our registrars, I think it might be helpful if you explain what are Levater-Ani trigger points.
So trigger points, you know what trigger points are? They're knots, right? You can feel them in your neck and shoulders. I'm sure you've got them too. You can get them in the pelvic floor because that's a muscle. And what you would identify is you could feel a change in the tissue, so a bit of tension and some sensitivity. So you would actually have to ask them, do you feel pain here? And they would say yes, no. They would respond to that pain. So they'd either try and pull away, they try and close the legs down. Their facial expression would change as well. But the trigger points are usually sensitive to touch. You don't need a lot of pressure to identify it as well. And it would be a change in the tissue structure. So it would almost be, it's like badly cooked spaghetti that's stuck together. It's that concept. So you can, they're not sliding past each other as they should be. They are stuck together and you can feel that tension sitting over there. It's more difficult, which is why the pain conditions won't be treated by a physio who doesn't have sufficient experience. They don't know how to feel and find it. Yeah.
And it can be caused by the surgery. And
It can be caused by surgery,
musculoskeletal
yes.
conditions, and it can cause dyspareunia.
Hmm.
So it's just for the registrar, I want to make you aware of that because we don't always teach you how to evaluate the pelvic floor muscle itself and do the pain mappings you was talking about. Actually very helpful. Sometimes you have patients even with chronic pelvic pain, and we will touch on pain after this session, but we know that you are actually helping us to try and resolve that type of pain. So thank you very much.
Can I add one thing? I do avail myself. So my contact details out there. Feel free to WhatsApp me and say, I'm looking for a physio in the following area. Is there anyone that can assist me? Can I refer a patient to you today? Can they come see you at the clinic? We don't have a waiting time for the clinic. We get them in on the day. As long as they're there on a Tuesday, we're happy to see them because we understand the logistics. So you're welcome to contact me, email me, questions, referrals, physio score referrals. Thanks again.
Thank you.